So, hello again. As caregivers, we are challenged by changes in the mental status of the folks that we take care of, and it can be very tricky and complicated at times. So, the lesson we're about to embark on hopefully will give us a platform to make these changes in mental status more understandable and perhaps lead to better treatment. So with no further ado, we'll begin with the case. So as you can read, Mr. Flabitz is a 78-year-old recently widowed gentleman, and he's been admitted for a pretty common malady these days in the elderly. He fell and fractured his left hip. And typically this is a pretty straightforward surgery with a 4 or 5 day post-operative convalescence on the orthopedic unit, and then a transfer to a rehab unit for 2 or 3 weeks, and folks typically have great outcomes. And if you look at Mr. Flabitz, he's got a number of chronic illnesses, adult onset diabetes and high blood pressure. He also suffers from emphysema and osteoarthritis, diseases of aging, many of them. But after the surgery, which is a resounding success, his hip is pinned, on his second post-operative day, his nurses describe him as increasingly tearful and frequently voicing a desire to join his departed wife. In addition, they say at nighttime he appears hypervigilant and fearful, seems to voice a lot of paranoid ideas, and that second post-operative night he actually physically pulled out his IV line and his urinary catheter, claiming that he was being poisoned. In talking with his adult children, they go on to say they've been worried about him for the last year and a half, even before his wife passed, because they've noticed his memory's been changing and declining. His hygiene, he'd been a very meticulously groomed fellow. His hygiene has dramatically fallen off. They say he's had a lot of difficulty with driving, using not a cell phone, but a landline, and even trouble preparing meals. They also describe a total loss of interest in his lifelong hobbies, golf and woodworking. So we've got 6 sentences here, and they're just loaded with information, but, you know, they take us down different trails, don't they? I mean, as we read this, at first, you know, we're taken by the loss of his wife 9 months before the surgery, and he's very tearful about this and voicing he wants to join her. So we might be thinking this is a complicated bereavement. But then we have these behaviors at night and these changes in mental status that he's never evidenced before, and those are hard to understand. And then lastly, his children kind of give us a background that perhaps he's had maybe a slowly evolving dementia. And, you know, we're left as caregivers and as clinical providers trying to sort this out, somewhat like the chicken or the egg. And most importantly, how are we going to manage this? Because he's having a dickens of a time recovering. So let's begin. This lesson is about the clinical differences between depression, delirium, and dementia, the 3 Ds, if you will. And, you know, here's where Latin serves us. So depression is from the Latin deprimere, to press down. To press down. Delirium is from the Latin deliria, out of the furrow. You know, the farmer plowing his field, and now suddenly the plow goes out of the furrow. And dementia is from the Latin demens, madness. So we kind of get just a little hint, a little tip of the iceberg, that these 3 conditions are very different just from their Latin roots. But we need the overview first. Simply put, elderly patients, much more so than younger patients, less than 55, are just at a high risk for depression and cognitive disorders. And cognitive disorders can break down simply into acute or chronic. And by acute, we mean hours to days. By chronic, we mean days to years to decades. And delirium certainly falls under the acute dimension in terms of the time frame, if you will, and dementia falls into the chronic, the very long-term time frame. But here's where it becomes a little bit complicated. Elderly patients can have simultaneously both mood and cognitive disorders, both all at the same time. It's possible for a patient to have dementia, depression, and delirium, and we have to sort those out and treat them accordingly. So the trick to all this, both for clinicians and I think even for caregivers, is just trying to get a read on what the potential diagnosis might be, because that's really critical to effective intervention and treatment. So, like anything in a medical condition, it begins with just simply an evaluation. And for Mr. Flabitz in a hospital setting, he's a bit of a captive participant, it begins with assessing his cognition. And you'll notice there's a number of acronyms here: the Mini Mental Status Exam, the Montreal Objective Cognitive Assessment, the Mini-Cog, and the Clock Drawing Test. These are instruments that are used all the time in the doctor's office, at the bedside, to just get a very quick screen about the patient's ability to function cognitively. Are they oriented to time, place? What's their immediate recall like? What's their delayed recall like? What's their concentration like? Can they read? Can they write? Can they understand what they read? Can they follow commands? Can they draw designs? So they measure different parts of cognitive function. So we begin with Mr. Flabitz just assessing his cognitive status. And it can break down simply into, is he impaired or is he cognitively intact? The second piece of the evaluation is trying to determine the patient's ability to perform ADLs, activities of daily living. And they break into two branches, if you will. Basic ADLs, which are for, dressing, grooming, toileting, and feeding oneself. And instrumental activities of daily living, there's actually 15 of those, but can the patient operate instruments of daily life? A phone, a remote control, a microwave? Can they read and understand what they read, tell you about what they read? Can they take notes? Can they make change? And so forth. And then the third part of the evaluation as we kind of proceed there. And of course the second part, quite often we may have to get history from collateral informants, spouses, family members, caregivers. The patient may not be able to tell us, or may fake bad, or fake good, for that matter. The third part of the evaluation is screening for depressive symptoms, and here comes some more acronyms. We've got the Patient Health Questionnaire, 9 questions, very quick. These all have to do with depression. And then we have the Geriatric Depression Scale. These are 15 questions that are specifically designed for patients 55 and older that have to do with mood. So we're looking at cognition, activities of daily life, function, if you will, and then depressive symptomatology. And at all points in time in the evaluation of an elderly patient like Mr. Flabitz, we want to assess for self-harm. He's already voiced kind of passive ideation. He wants to join his departed bride. And as you know, elderly patients with multiple medical conditions, and Mr. Flabitz has multiple medical conditions now complicated by an acute fracture, they comprise the highest risk group for not attempted suicide, but completed suicide. So this is truly a high-risk group. So we always want to be very, very intense and scrupulous about evaluating suicidality. So we have these three conditions: depression, delirium, and dementia. So let's begin with major depressive disorder. We're familiar with this because we're all human beings. We all experience sadness, but major depressive disorder is a different type of animal, if you will. Depressive symptoms, as you know, are common in the elderly, but here's where they really impact the elderly greatly. They're quite well associated with poor, emphasize that, poor outcomes for ongoing treatment of their medical problems and an increased risk for suicide. That's a theme that we'll expand on. And this is the second bullet is fascinating. Depression in the elderly almost goes hand in hand, if you will, with certain illnesses. It's associated with stroke and Parkinson's disease. That makes sense. Those are central nervous system insults that in damaging neuronal tissue, they're also damaging some of the circuits that have to do with mood and well-being. They're associated with cardiac disease. Well, if we have cardiac disease, we don't perfuse, we don't oxygenate our central nervous system. So again, we're at more risk. And they're also associated with depression is also very commonly associated with multiple types of cancer. So right away, the good news is Mr. Flabitz is in the hospital for an orthopedic problem. The bad news is we know he has some pre-existing cardiac disease. So what is the definition of major depressive disorder? Well, the definition is the same in the elderly as it is in the non-elderly, and it's simple, but it's profound all at the same time. This is not a situational adjustment problem. This is persistent, either sad mood or persistent loss of interest in the activities and day-to-day pleasures that we enjoy every day, most of the day, for at least 2 weeks. So this isn't, a 2 or 3 day slump or bad spell. This is persistent sad mood and or loss of interest every day, most of the day, for at least 2 weeks. And 4 of the following symptoms, and you can see the list is long. Either disturbances in sleep or appetite, dramatic changes in energy, concentration, persistent feelings, perhaps even not rational feelings of guilt or helplessness or hopelessness or worthlessness. And then, this is not so much a symptom as it is a sign, either motor restlessness, where people with major depression just feel agitated, can't sit still, they're hand-wringing, hair-pulling, gnashing of teeth in the biblical fashion, or they have motoric apathy. They talk slow, they move slow, they think slow. And then you can imagine if you're experiencing these symptoms, this onslaught of symptoms every day, most of the day, for 2 weeks, it's not a leap to imagine that if this is how life is going to continue to be, perhaps I'd be better off if I wasn't here. My family would not be burdened by me. It would be a relief to be gone. So there is an exclusionary piece to this diagnosis, which is these symptoms are not caused by a medical condition. For example, folks with profound anemia, they don't have much energy, they sleep a lot, they don't move very fast, they don't think very well. Same with hypothyroidism. Or these symptoms can't be secondary to a substance abuse disorder, an alcohol or a drug problem. So that's the diagnostic criteria for major depressive disorder. And remember what we heard about Mr. Flabitz, total loss of interest in the passions that he loves, woodworking, and what was it? It was a golf? Yes, golf, I think. And, he's certainly having trouble sleeping for those post-operative days, and he's voicing suicidal ideation. So there's a couple of red flags that are kind of leaping up at us. The good news is there's abundant treatment for major depressive disorder. Before we had medicines for major depressive disorder, the talking cure was very helpful. This is now known by fanciful terms like psychotherapy, and there are multiple different types of psychotherapy. But there's strong evidence that talking about depression, rethinking problem solving, if you will, can be very useful. The trick is it's laborious, it can be expensive, it can be difficult to access if you're an older person that may have problems with transportation, frailty, ambulation. We also have medications, and it's a wonderful era. No medicines existed to treat depression until the early 1960s. Now we have 32 FDA-approved antidepressants. It's a bit like the explosion in antibiotics. And they're all equally effective. They all have their own blessings and curses in terms of side effects and tolerability. We treat depression now with devices. The most recently approved device is a transcranial magnetic stimulator. This is done in an outpatient setting. It appears to be pretty effective for depression, but it's a bit laborious. It's daily treatments, 5 days a week for 6 weeks, and also somewhat difficult to access due to insurance and expense. And then last but not least, I think for those patients, particularly elderly patients that may not respond or may not tolerate the above treatments, we have electroconvulsive therapy. As frightening as the name is, it's in its 4th generation. It's exceedingly safe, exceedingly effective. But of course, it carries somewhat of a stigma from media and movie and literature from the days when it was in its 1st and 2nd generation. So the great news about major depressive disorder is it's imminently treatable. Now, this is a bit of a detour. Bear with me. This is a dated term. It's called pseudo-dementia. False dementia. These are elderly patients who on first glance, on first visit, they appear to be cognitively impaired, because when you do that first part of the evaluation, cognitive assessment, they typically answer, "I don't know. I'm not sure." They don't even take a stab at it. So this is a term, as you can see, it's quite dated. It was coined in 1961. To identify patients that had, here's the key, reversible causes of cognitive impairment. And the reason they were reversible is that these patients did not have dementia, although at first glance they looked like they did. They had depression that was untreated. And when it was treated, quite suddenly, if you will, their cognitive impairments vanished. It's no longer considered a diagnostic term. Nowadays it's considered more of a descriptor. And there are some folks that argue that maybe it's best to call it pre-dementia, because there is some evidence that if you see an elderly person that on first glance looks to be cognitively impaired, but you make a diagnosis of depression and you treat it and they respond, that the caregiver and the clinician should still be on their toes downstream, because there's some evidence that maybe this is the leading edge, if you will, of a dementing illness. So what about delirium? Remember the Latin root, deliria, out of the furrow. So the key here is in the first bullet. This is an acute, a very short-term, confusional state. It's incredibly under-recognized in the hospital setting because folks have had dramatic interventions, surgery, chemotherapy, and they don't appear in their usual state, so they're not diagnosed with delirium. They're simply diagnosed as, well, this is what we see post-operatively. The wondrous piece about delirium is it's reversible, generally speaking. There are some cases of quote, chronic or permanent delirium, but they're rare. And the hallmark of delirium, the real piece de resistance, is this condition is caused 95 times out of 100 by an underlying medical condition. Maybe it's a urinary tract infection, maybe it's pneumonia, maybe it's a change, a new medication to treat an underlying medical or surgical condition. Maybe it's a pain medicine, maybe it's a new antibiotic, but typically a medication review will kind of reveal the offending agent, typically a kind of a review of medical conditions. Let's look at the patient's urinalysis, let's look at their chest x-ray, let's look at their brain MRI will reveal the underlying medical condition. And once that's addressed, the delirium fades. It's incredibly common, up to a third of hospitalized elderly patients. And the reason it's just of critical importance is it's associated with increased mortality. So if you're older, you go into the hospital for a medical surgical condition, and in your hospital course, you're diagnosed with delirium on top of your underlying medical or surgical condition, you're immediately at risk for increased mortality. You're certainly at risk to stay in the hospital longer, and you're also more likely to not go home, but to go to nursing home placement after you're discharged. So it's a serious condition. How do we make the diagnosis? This is where the pre-morbid history is just critical. How was the patient functioning cognitively and in terms of activities of daily living before they came in the hospital? So think about Mr. Flabitz. The family says, gee whiz, he was declining before he came in. But it wasn't something that was acute. It was chronic, remember? 12 to 18 months. So he had a pre-morbid history that at least suggests or smacks of a dementing process. What about his medications? Well, he's got 4 chronic medical conditions. My hunch is he's probably on 8 to 10 medications. Did they get shuffled around in the hospital? Did they get changed? And maybe his attending physician said, gee whiz, Mr. Flabitz is on an old anti-diabetic medicine. While he's here, I'll upgrade him to something new and better, but perhaps not at all tolerated. Has he gotten a brand new medicine, perhaps to cover the risk for infection, or a brand new medicine for pain? So a medication review will often be incredibly revealing and diagnostic for delirium. We certainly want to look at on the spot, within the 24 hours after delirium emerges, the patient's blood work and imaging, their urinalysis. We want to do, again, a mental status exam. But in the mental status exam, what we really expect to see is inattention. Delirium, it's almost impossible for the patient to stay on point, to concentrate. So we have this wonderful, very short, takes about 10 minutes. It's called the CAM, the Confusion Assessment Method. And it simply demands that to make the diagnosis of delirium, the patient must meet the first 2 criteria. That they must have confusion that comes on suddenly, not something that's emerging slowly over days, weeks, months. Acute onset of confusion. It must be manifest by inattention. And then they have to have one of either 3 or 4, disorganized thinking or altered level of consciousness. Altered level of consciousness ranges from stupor to mania. Okay? So think about Mr. Flabitz. Okay? Second postoperative day, he's tearful and he's wanting to join his wife. But what else is he doing? He's paranoid. He's hypervigilant. He's pulled out his catheters because he thinks he's being poisoned. So he's delusional. He's got disorganized thinking. So treatment, well, you're probably already one step ahead of me. Since delirium is usually caused by an underlying medical condition, treatment of delirium begins with identifying and treating the underlying medical condition. If they have a urinary tract infection, golly, let's find out what that bacteria is sensitive to, and let's treat it with an antibiotic that's going to knock that bacteria out. If they've got medication mismanagement or a medication change, let's kind of go back to square one and maybe go back to that older anti-diabetic medicine, or maybe look at a different type of pain management. Certainly with delirium, we want to optimize the sleep-wake cycle, because you already got the impression from Mr. Flabeets that he's up through the whole night. He's vigilant. He's paranoid. So can we get him a night's sleep regularly? We want to frequently reorient him. This is where the nursing staff are truly angels. You know, Mr. Flabeets, we're certainly not here to harm you in any way. Just you're in the hospital, you've had your hip repaired, you fractured it. Frequent reorientation. We want to avoid any unnecessary interventions. Just try and keep things stable medically. No new medicines if we can avoid it, with the exception of what we need to treat the underlying medical condition. And then we'd really like to avoid restraints, because you can imagine here's a 78-year-old gentleman that's paranoid and he thinks he's being poisoned, and now the caregivers are going to tie him down. Okay. Antipsychotics, very low dose, very short duration, are incredibly effective to stabilize patients with delirium while we're hunting down the underlying medical cause. So the last piece of the 3D puzzle, the 3D challenge, is dementia. And of course, you know, as caregivers, I think we're all intimately familiar with this diagnosis. You know, this is an age-associated, progressive, neurodegenerative disorder associated with cognitive impairment. You know, so it's not something that patients typically self-report. They might say, oh, my memory is a little bit off, but everything else is Jim dandy. And, you know, we know the evolution. Kind of the first piece of this is short-term memory loss. As that expands and magnifies, that begins to impact ability to do activities of daily life, beginning first off with instrumental activities, and then as we begin to really lose the capacity for learning and any short-term memory at all, we're not able to do basic activities of daily living. And of course, as this condition progresses over years, kind of the final pathway, as one might imagine, is behavior problems emerge. So if cognitive impairment is suspected, here's additional cognitive screens that we've talked about before. We talked about the mini mental status exam, the Montreal objective cognitive assessment. The MIS is the memory impairment screen. It takes about 3 minutes to do. The SLUMS is the St. Louis University mental status, and there's the good old clock drawing test. That last bullet is maybe a bit feeble or maybe underwhelming. Pharmacologic treatment demonstrates improved cognitive functioning. Maybe that's also an overclaim. You know, there's some evidence that the 4 approved medicines by the FDA to treat Alzheimer's dementia do have benefits short-term in cognition and in activities of daily living. But that's the best we have in 2018. So let's try and sum it up. Hopefully this table will give us a little more better definition. And there's the 3Ds, depression, delirium, dementia. And maybe the first bullet is perhaps the best hint, if you will. So the onset of depression, typically remember, it's depressive symptomatology every day, most of the day, for at least 2 weeks. So there's an evolution here over weeks to months. Delirium is an acute confusional state, hours to days. Here are patients that are relatively stable, and overnight there's a dramatic change in their cognition, if you will. And then dementia is, as we know, is a very long-term process that evolves over years. In terms of the mood piece to these three different conditions, obviously for depression, sad mood, apathetic interest is sort of the centerpiece. For delirium and dementia, this is quite variable. Quite often in dementia, the patient's mood will be relatively stable. In delirium, it can fluctuate. Sometimes folks with, quote, hypoactive delirium may be diagnosed initially as depression. Sometimes folks with hyperactive delirium, they might be diagnosed as manic, so it's variable. The course, again, here's where delirium stands out. The course is typically acute and very responsive to treatment of the underlying medical condition. Depression, much more of a chronic course, but very responsive to talk therapy, to medicines, to treatment with devices now. And of course, the course of dementia is incredibly chronic, and we don't have effective long-term treatments. We don't have a cure. There's a progressive decline. In terms of self-awareness, as you can see in depression, typically folks with depression, elderly folks with depression, may voice concern about their memory problems. You know, I'm just not thinking clearly because I just feel so bad, so sad, so low down. In delirium, they may have awareness, they may not. You may see a patient with delirium at 9 in the morning and they'll be quite confused. You'll return at 3 in the afternoon and they'll be better oriented. So it's an acute confusional state that fluctuates. And of course with dementia, quite often in terms of self-awareness, they may be completely unaware or even minimize or hide their cognitive problems. In terms of activities of daily living, so basics, eating, dressing, feeding, grooming. Mr. Flabeetz, had a decline in hygiene, which kind of goes perhaps to dementia, but you can certainly see that in depression as well. In terms of delirium, the basic ADLs are typically intact, but they can be impaired. And then, of course, in dementia, the basic ADLs are usually intact early in the disease process, and then as the patient progresses, they are lost. In terms of instrumental activities of daily living, operating equipment, it can go either way in depression. Delirium, as the chart indicates, it can go either way, but if this is an acute confusional state where inattention is the hallmark, it's quite often impaired, but again, acutely. And then in dementia, they may have instrumental activities, at least early on. Some of them might be intact, but they fade as the disease progresses. So let's go back or let's conclude with some takeaways. So some simple things. We've got the 3 Ds: depression, delirium, and dementia. So generally speaking, any acute behavioral or mood change suggests delirium. That's sort of just a little guide. This is a guide. When medical conditions have been ruled out, is this an underlying infection? Is this a medication change? Is this a change in the caregiver? Is this a change in environment? Then we want to kind of shift into looking at, is this depression with or without cognitive impairment? Remember, you can have both simultaneously. Patients with dementia are far less likely to self-report cognitive problems than are patients with depression. And then the good news, the really good news for patients and caregivers and providers is that depression and delirium generally respond well to treatment. So let's return to Mr. Flabeetz. What do we want to say? He's had a fall, he's fractured his hip, he's still bereaved and grieving. He's got medical conditions, but on day 2, there's that acute piece, he's tearful and voicing suicidality. But we can maybe push that off to grief. Maybe this is just depression that we're seeing. He's in a hospital unit. But there is the kicker, that 4th sentence. He's fearful and paranoid at night. That doesn't often or commonly go with grief. And he's pulling out his IV and his urinary catheter because he's confused. He's confused. But his adult children go on to say that even before he lost his wife, they were concerned about maybe an early evolving dementing process, and they describe a total loss of interest in his lifelong hobbies. The question I'd want to ask him is, when did that take place? Was that 12 to 18 months ago? Was that after he lost his wife? Was that in the last 3 or 4 months? So walking in or being asked to see Mr. Flabitz, I'd probably say, just shooting from the hip, that it sounds like he had an evolving early dementia, and it sounds like he probably had a reactive depression because of the loss of his wife, and that he also has an overlying delirium. So let's look real close to see if there's been any medication changes, see if he has an infectious process. Let's perhaps start treating a depression. Let's try and maximize the management of his dementia. And that's where we're going to spend some time with the family looking at what happens next in the hospital. But first off, let's stabilize the delirium. Let's treat the depression if there is one. And then let's look at long-term care. So hopefully today's vignette offers some guides for all of us to manage what can sometimes be a very complicated elderly patient.